So basically, in this session, I'm just trying to answer the most important question. What causes hypertension? It's not an easy answer. What we know is we know bits and pieces from here and there. And we are going through an era where the definitions are changing rapidly. And I would just like to dwell a little bit into the rationale behind these changing definitions and when to suspect a secondary hypertension and what are the different methods, the pros and cons of each of these methods available for blood pressure measurement. Management of hypertension and gestational hypertension, probably I'll be dealing in the next session. Now, hypertension is a disease which is actually as old as mankind. It has been demonstrated that the Egyptian mummies, the civilization that existed around 3000 to 3500 years before Christ era, had evidence of atherosclerosis and organ damage because of that. But unfortunately, nobody knew what causes hypertension. And even now, we are not in a very good shape. We know a little bit here and there. So one of the first attempts to identify what is the cause of hypertension, this was done by someone called Irving Page in the 1940s. And his hypothesis was basically hypertension is a mosaic of various factors that interact with each other. And it's almost like around 75 or 85 years down the lane, and this is where we stand now. Now, what we know is hypertension happens in a genetically susceptible individual, and genetic susceptibility doesn't really mean that somebody will have hypertension. You need to have multiple hits acting on a genetic susceptibility. This includes many environmental factors, things that happens after the individual is born, your diet, your lifestyle, and probably there might be hemodynamic, humoral, endocrine, and a neural basis to everything. So this was what I was telling in the beginning. So this is actually a CT scan taken from an Egyptian mummy. There is a study called a Horus study where they are trying to identify the evidence of atherosclerosis in primitive population. So they have mummies from different parts of the world, and around 34% of the ancient humans had plaques which are considered as pathogenic. And on the other side, this tribe is a Yanomamo tribe that lives deep down in the Amazon basin. They are kind of cut off from the modern day civilization. And because they are living deep inside the jungle, their diet is a kind of a little bit primitive diet, and they don't have access to salt. And the mean sodium excretion in it usually parallels with the dietary intake. It's as low as 20 milligram, whereas actually for us, the mean sodium excretion can be somewhere around 100 or 150 milligram, depending upon the dietary intake. And none of them are hypertensive. They're very healthy. The body mass index is somewhere in the 20 range. And interestingly, we all know that as age increases, the blood pressure keeps on increasing. That phenomenon is not documented in these individuals, and none of them are obese also. But again, when this primitive population, this is not the only population who is free of hypertension or any of the lifestyle diseases. But what happens is when they move away from their native surroundings and when they has access to the modern civilization, it is actually shown that they have all these diseases in an exaggerated fashion also. So what I just wanted to point out is probably hypertension is a kind of a side effect of probably the modern day affluent lifestyles. Now, hypertension, it was long known that hypertension is a property of the kidney. So there is a type of rats called DAL, salt sensitive rats. So when we feed sodium or salt on these rats, the blood pressure shoots up. Unlike a normal rat, which would be able to excrete salt to a certain extent. So when a kidney is taken from this DAL hypersensitive rat and transferred to a non-hypertensive rat, it has been documented that the non-hypertensive rat becomes hypertensive. And again, there is a very high concordance in monozygotic twins. And again, we know that children who are born with a low birth weight, preterm or near-term infants who are born with a low birth weight, generally their nephrogenesis is not as good as a term baby that's having normal birth weight. So this is something called nephron underdosing. And a good proportion of this children who are born as low birth weight children, when they are followed up in long term, they develop hypertension. Again, meaning that, again, pointing to the fact that there is something that's abnormal with the kidney that has been there in the in utero life. Now, normally, what happens is, let's say we all take a lot of salt. So, what happens when we take salt? Let's say a normal individual, completely healthy, and we are kind of doing an experiment. We are loading him or her with a liter of normal saline that contains around 9 gram of sodium chloride. That's almost double of the recommended daily allowance of sodium chloride. So, what happens when you give a saline infusion over 1 or 2 hours to a completely healthy individual who doesn't have any risk factors? Nothing is going to happen. The blood pressure is not going to shoot down. And in a couple of hours, the entire additional sodium we have infused, that's going to be excreted via the kidney. So there's a phenomenon called pressure natriuresis. So normally in a state of health, where you have a completely normal kidneys and a completely normal vascular endothelium, you will be able to excrete salt, which means that you are resistant to the hypertensive properties of the salt. So what usually happens is when we load salt, there will be a suppression of the renin, angiotensin, aldosterone system. That's primarily one of the systems concerned with the reabsorption of sodium. And there's an abundance of vasodilators. So your blood vessels tend to dilate when you are given salt. So when these blood vessels tend to dilate, that actually translates to increased renal blood flow. And again, when there is a lot of blood in the kidney, the renal interstitial pressure starts increasing. And this again actually acts as a deterrent to sodium reabsorption by the renal tubule. So what eventually happens is, in a salt resistant individual, ideally everybody should be salt resistant. Every healthy individual should be salt resistant. And when we give salt to a salt resistant individual, within a matter of a few hours, the entire salt will be lost by the kidney. So this is the normal response. But whereas some people, they exhibit a phenomenon called salt sensitivity. So instead of this vasodilatation and reduced renal absorption of salt, there are individuals who vasoconstrict. Eventually, such individual, and at the same time, their kidney starts reabsorbing a lot of sodium also. So what happens is, these individuals, they have a RAS system that is not sensitive to salt loading or depletion, because primarily their kidneys are kind of set in the reabsorption mode. So such individuals, when they are on a salt restricted diet, their blood pressures can be normal. Whereas on the other side, when the salt intake increases, the blood pressure keeps on increasing. Now we know that actually there are certain genetic factors that actually is associated with the salt sensitivity, and whatever letters on the kidney, that basically most of them are either hormones concerned with the sodium reabsorption, or various transporters, or various mediators of salt reabsorption. So in certain individuals that exhibit salt sensitivity, there are polymorphism, which means that their kidneys are kind of genetically tuned to reabsorb more sodium. And on the other side, their vessels are also kind of sensitive to the effect of salt. So instead of vasodilatation, that is a normal response we anticipate in a healthy individual, their vasculature constricts. And there are certain factors that causes salt sensitivity. So normally when a healthy child is born, the child is always salt resistant, provided there is no IUGR, it's a normal baby. But as we age, pupil starts exhibiting salt sensitivity. That is the reason. So that was why I was telling in the Yanomano Indian tribe example, they don't have access to salt. So since they don't take salt, the only sodium they are getting is basically from the diet they are eating in the, like it's not exactly salt, maybe the sodium content from the rest of the diet. So that their sodium content remains the same, whether it's a newborn child or whether it's a very old individual. So what happens to us who are actually having access to the amenities of the modern day civilization is, Most of the time, even though the recommendation is around 4 to 5 gram of salt, we end up taking 10 or sometimes even 15, depending on the lifestyle. The more processed food we are eating, we end up taking 10 to 15 grams of salt in a day, which is almost 3 times. And females are vulnerable to salt sensitivity. And again, the reasons exactly are not known. And the other important thing is excess of sodium, overweight, and a potassium poor diet. I'll come to that, how actually a high potassium diet is going to protect against hypertension. And a low birth weight and small gestational age, because they are born with a less number of nephrons. And again, the nephrons are kind of set in a sodium reabsorption mode. They end up having high salt sensitivity. And generally, it is believed that most people of the African descent, almost around 75 to 80% of the people of the African descent is salt sensitive, again because they have certain genetic mutations which probably makes them protecting against this trypanosomiasis and all, but unfortunately that makes them vulnerable to hypertension. And then some people have a very high sympathetic activity, and there are certain variants of epithelial sodium channel. So that is actually being depicted in the kidney diagram. There are a lot of sodium reabsorbing channels in the kidney, and some of them have polymorphism, which means that they are not really susceptible to the inhibitory effects that happens in the normal stage. Then insulin resistance, obesity is going to be a major risk factor for salt sensitivity and chronic kidney disease. So this is what happens when we give salt or sodium loading in a salt resistant individuals. There is a sharp increase in the sodium, urinary sodium excretion, and at the same time the arterial pressure keeps normal. So this is what happens when we load sodium to an individual who is salt sensitive. Here what happens is, as the sodium intake increases, the blood pressure keeps on rising, and the urinary sodium excretion, instead of being sharply elevated, this kind of shifts to the right side, which means that they tend to get sodium. And for such individuals, it's very strict that the sodium consumption, the salt consumption has to be kept at around 4.5 gram per day. That is equivalent to a sodium consumption of 2 gram per day. And none of your antihypertensives are going to act in these individuals unless they are on a sodium restricted diet. And usually, in a general population, how much is the salt sensitivity? We don't really have much good quality, large population studies. In smaller settings, it has been found that almost more than half of the individuals, and especially in the recent studies, where actually there is a high prevalence of obesity, lifestyle diseases and all, the numbers are going to around 75 to 80%. They exhibit salt sensitivity. And again, salt sensitivity can be there in the absence of hypertension also. So that's something called normotensive salt sensitivity. Whether you have hypertension or whether you don't have hypertension, salt sensitivity is something that is really bad. Because when you have a normotensive salt hypersensitivity, your risk for subsequent cardiovascular diseases are relatively higher compared to the general population. Now, this was what I was actually telling. When a child is born as a result of, when it's a low birth weight baby, or there is a fetal malnutrition, placental ischemia, when the mother has a disease that predisposes to placental ischemia, the kidneys and the entire body is tuned to be in a state of high cortisol and high aldosterone. The kidneys will be sensitive to sodium. The kidneys are kind of tuned in a sodium reabsorptive mode, and eventually, as these children becomes older, they are more vulnerable to other cardiometabolic features like obesity, and eventually they develop salt sensitive hypertension. So this is a hypothesis that states that probably if the mother is healthy, you're going to have a healthy child, and the child is going to be healthy for the rest of their life. On the other side, if the pregnancy is unhealthy, if the mother is unhealthy, the mother has cardiometabolic risk factors, you're going to give birth to a child who is vulnerable to develop all these issues, the cardiometabolic syndrome, as the child ages. And for maybe 50 or 60 years, it was thought that kidney is the reason why individuals develop salt sensitivity. But now, in the last 10 or 15 years, the kidney-centric theory has kind of shifted towards the vascular endothelium. So there are abnormal mechanisms in the kidney, but what actually causes all these things is an abnormal vascular endothelium in the kidney. So we have been traditionally told that always sodium and water accumulate together. But we know that in certain individuals, they can accumulate a few grams of sodium in the absence of water accumulation. Sodium can accumulate non-osmotically in the vascular endothelium, skin, and possibly in the interstitium. This type of individuals, even if they restrict their sodium, it takes a long time for this non-osmotically stored sodium to go. So they tend to remain hypertensive even when they change over to a sodium restricted diet. So now the current hypothesis is salt sensitivity is a property of the renal vascular endothelium and probably modified by factors that happens in the postnatal life. So this was what the kidney-centric theory has moved to something like a vasoconstriction theory where the onus is on the vascular endothelium. Now, a high sodium diet, again, this is another new hypothesis that is coming up. Again, actually, this is emphasizing, creating a lot of emphasis on the way we eat. Now, a high sodium and a low fiber, low potassium diet is basically something which creates a milieu for hypertension. So you don't want hypertension. We need to be on a low sodium, a high fiber and a high potassium diet. So now it is known that there is gut microbiota and we have this lactobacillus. Then there is another group of microbes called firmicutes and bacteroids. Probably bacteroids is the thing we don't really want. And there is this ratio called firmicutes to bacteroids ratio and all, which is altered by the diet we eat. So when we eat a very high sodium diet, lactobacillus, wherever it is there, it is considered as protective. So there is a reduction in the lactobacillus species. And what happens when the lactobacilli is reduced is there is some immune activation of some T cells and all, and this creates a pro-inflammatory profile. And when there is a pro-inflammatory profile, there is a lot of oxidative stress happening. And this can be simply reversed by reducing the sodium content of the diet. And on the other side, when you take a very low fiber diet, when you are more into processed food and all, this high fiber diet, basically the bacteria will act upon the fiber and they will actually start producing a lot of short chain fatty acids. And this short chain fatty acid is considered to be cardioprotective as well as gut protective. And when we eat a very low fiber diet, there is a reduction in the short chain fatty acids, and the gut integrity is kind of compromised, and the gut becomes more having an inflammatory profile. And again, eventually, a high sodium, low potassium, and a low fiber diet creates an inflammatory profile where there is a lot of oxidative stress, and oxidative stress generally increases the vascular tone and blood pressure. Now, again, when we eat a high potassium diet, the potassium has a property of driving sodium out of the body. So when there is a very high potassium, they will downregulate some of the renal sodium channels like the sodium chloride co-transporter. That is where the thiazide diuretic acts. And subsequently, when we calm down, again a high potassium kind of inactivates epithelial sodium channel. That's where actually the drugs like spironolactone, triamterene and amiloride act. And again, as long as the kidney function is normal, it's not going to produce any hyperkalemia because whatever potassium there is extra, that gets excreted later down in the tubule. So this is something which is very important when we treat hypertension in an outpatient basis. You need to emphasize the sodium restriction. The amount of salt an individual can take in a day when they are hypertensive. I would say sodium restriction is something that should be practiced even when you are normotensive or even when you are healthy, because sodium is going to increase the salt sensitivity. We will never know unless we do a formal testing. We will never know. Even if our blood pressure is normal, there is a likely chance that we might be salt sensitive. And salt sensitivity is the forerunner of adverse cardiovascular outcomes 10 or 20 years down the lane. So first and foremost, every individual, it's good that actually we restrict the sodium to less than 4.5 gram in a day. And roughly that means it's like a level teaspoon of salt. So in a hypertensive individual, the best advice you can give is nobody has a kitchen balance that can accurately weigh 4.5 gram. Cook everything without salt and take one teaspoon, take a scoop of sodium, level it, and once it is leveled, that is going to be somewhere between 4 to 5 gram, and that is the amount of sodium the person can take in a day. And on the other side, ask the individual to take more potassium. And obviously, do not go for this fancy salt, like there are so many salts available, but the best way is actually to take fruits. And vegetables. Increase the intake of fruits and vegetables. So that will be a simple solution that actually will be capable of bringing down the blood pressure by at least 8 to 10 millimeters of mercury. And again, whatever drugs you prescribe, you are prescribing diuretics, you are prescribing angiotensin receptor blockers or AC inhibitors. None of these drugs are going to work in the absence of sodium restriction. And the effect is kind of reduced. I won't say it's nullified. The efficacy, the antihypertensive efficacy of almost all antihypertensive comes down when you are not salt restricted. And again, there is another group of, don't assume that everybody is salt sensitive. There is a small proportion of individuals where they remain hypertensive, whether you restrict the sodium or not. And most of the time, this subgroup is very less. We don't really know much of them in the healthy population. Most of the time, these are the group of individuals who have kidney disease and like most of the secondary hypertensions usually fall into the salt resistant. So there could be some essential hypertensive who are salt resistant also, but majority of the essential hypertension you come in your day-to-day practice exhibit this phenomenon of salt sensitivity. Now, this is something which is really important. Now, when I started my MBBS, hypertension was very clear. It was 140/90. Then, over the years, there has been some changes in the definition of normotension. Now, these are the two recent guidelines. WHO again actually sticks with the 140/90 for hypertension. But the major change has happened in this area. This is the European Society of Cardiology that has defined normotension as less than 120 and diastolic blood pressure of 70. Whereas this is the ACC-AHA guideline. Again, this has come 1 year later and they have stick to the definition of 120 and 80. And these two groups has actually looked into the almost similar evidence, and basically this is an expert consensus based on mostly observational data. And there was a group called pre-hypertension. Now that pre-hypertension, the terminology has been changed to elevated blood pressure. So as per the ESC criteria, it is 120 to 139 and 70 to 89 diastolic pressures. Whereas for the ACC-AHA, it is 120 to 129. Here you can see that the ACC-AHA, the stage 1 hypertension is 130. And a diastolic blood pressure of more than 80 and falling within 89 is stage 1 hypertension. Whereas ESC is going to stick on with as with the WHO, it's 140/90. And 140/90 for ACC-AHA is considered as stage 2 hypertension, and that usually warrants treatment. This particular group, elevated blood pressure and stage 1 hypertension, even though they are labeled as not normal, they do not warrant hypertensive therapy unless certain other criteria is going to be fulfilled. And now what is the... Okay, now this is in an outpatient setting. So when someone comes to the emergency, let us say someone had a road traffic accident, had a few scratches and otherwise no major injury, comes to you with an elevated blood pressure, do not actually jump to label it as hypertensive emergency or hypertensive urgency or not. So when someone presents in the inpatient setting or in an emergency setting with an elevated blood pressure, again, this is 130/80, this keeps on changing depending on the guidelines. So now let us say there might be two situations. One is actually it's very high. Let's say diastolic blood pressure of 180 and systolic blood pressure of more than 180 or a diastolic blood pressure of 110 to 120. What you need to see is whether there is any target organ damage. Sometimes there might be target organ damage which is pre-existing. You need to see whether, for example, what evidence of target organ damage you are going to see. Let's say someone had a cardiac failure previously documented. It was a treated cardiac failure, whether there is a worsening of symptoms. Or the patient had kidney failure, creatinine was 1.3 or 1.4, whether there is any increase in creatinine, whether there is any papilledema. Now, if there is any evidence of new or worsening target organ damage, that is a hypertensive emergency, which means you don't have time to treat. You have to act immediately. But if there is no new onset target organ damage or worsening of target organ damage, previously we used to call it as hypertensive urgency. Now it is called as an asymptomatic markedly elevated blood pressure, where you can kind of have a wait and watch policy. And somebody comes to the inpatient setting with a blood pressure less than 180 and a diastolic blood pressure less than 110. Again, there is no indication to this asymptomatically elevated blood pressure and markedly elevated blood pressure, asymptomatic individual. These are not the candidates for immediate pharmacotherapy. But whereas someone presenting, a hypertensive individual presenting with a target organ damage or previous target organ damage was there, then there is a worsening of target organ damage. This is an emergency situation where you need to bring down the blood pressure. Whereas these two groups, this particular group where the BP is not elevated, not markedly elevated, probably you can actually ask them to come to the outpatient department in future and get properly evaluated. Whereas this type of individuals, you will have to hold them for a little bit of time just to ensure that they are not progressing to the hypertensive emergency. Now, over the last few years, this definitions of blood pressure has changed, and which actually means that when we keep 140 over 90 as the threshold for hypertension, we'll see that maybe 25 or 30% of the world population might be hypertensive. When that is being brought down to 130 by 80, the proportions might be somewhere between 50 to 60, and when it is lowered to 120 by 70, almost 80% of the population will be hypertensive. Now actually, this is perhaps a very good ground for the conspiracy theorists telling that it's the pharma which actually keeps this policymakers keeps on reducing the blood pressure. Now let us see what is the basis on which this normotensive targets, the cutoff for normotension is being brought down in the last 10 years. Now, before going to that, what you need to keep in mind is both systolic and diastolic blood pressures are important. When you are treating hypertension, you need to bring down the systolic and diastolic blood pressure to the targets. And systolic blood pressure has a slightly stronger, I would say, a 3% higher relative risk of adverse cardiovascular events. Whereas, depending on what is the event you are looking, the contributions might slightly vary, but overall, both systolic and diastolic are problematic. Systolic, I would say, is a little more problematic compared to the diastolic blood pressure. And again, we were actually taught, at least actually when I was doing MBBS, it was taught that older individuals probably you can give some allowances to the systolic hypertension. If there is only systolic hypertension, this group of individuals are going to have a better profile compared to those with systolic and diastolic hypertension. What you can say is, I don't know whether you can make out this slide. The green is the cardiovascular events in people who have isolated systolic hypertension. What you can see is the proportion as age advances, the proportion of the contributory role of systolic hypertension to adverse cardiovascular events is actually very high, and probably there is a kind of a little bit of a leveling effect once the individual is older than 80. So a systolic hypertension in an older individual should not be neglected. It needs to be treated. Whether it needs to be aggressively treated or whether it needs to be treated less aggressively, that's actually a different question which we will be dealing in the next session. So again in the same slide, you can see that this blue thing is actually the contribution of isolated diastolic hypertension. You can see that as age advances in the older age group, 60 plus age group, isolated diastolic hypertension probably is not going to be a big issue, but isolated systolic hypertension is a cardiovascular risk marker. Now, this is actually the large population-based study, trying to correlate how blood pressure is associated with cardiovascular disease in the absence of risk factors like healthy pupil. So what you can see is that when the blood pressure, systolic blood pressure is less than 100, the risk is going to be very much lower. And you can see that even now, actually, the threshold for hypertension is 130 and 120. Sorry, now it's 120. So now actually the risk is even higher between this range of 110 to 120 also. And the risk is actually the lowest. The protective effect crosses over somewhere around 100 millimeter. So in a healthy individual, a blood pressure, a systolic blood pressure of 100 millimeter, there is nothing to panic. Do not actually label this patients as hypertensive. The system is actually protecting them against an adverse cardiovascular profile. Whereas this might not be normal in a patient. For us, the target is not going to be 100. Do not actually jump to reduce the blood pressure to 100. That's an altogether different scenario. What I'm talking is the type of people who come to the OPD practice with a blood pressure of systolic blood pressure of 90 and 100. Please do not attribute all their symptoms to the blood pressure. Probably the minor symptoms, and unless they have some postural hypotension, unless they are going to be dizzy, they cannot work, just leave it to them. And do not ask them to increase the sodium intake. In an asymptomatic individual with a blood pressure of 100 or 90, that's going to be perfectly fine. And again, these are a few data from the large population-based studies. You can see that the risk is actually, this is a unadjusted thing. Even after adjusting for all covariates, you can find that this ideally, if 100 millimeter of blood pressure is protective and 110 is protective, the graph should start from here. And you can see that it's actually, whether it is systolic or diastolic, it's higher. And again, bringing down the cutoff of hypertension from 140 to 140 and a diastolic blood pressure from 90 to 80, the risk remains higher. So, what is going to be the ideal blood pressure? If we look at the trial data, less than 120 is ideal. But now, if you ask me a question, somebody comes with no other risk factors, comes with a blood pressure of 125, does the patient needs a pharmacotherapy to reduce it to less than 120? The answer is no. The answer is it depends on the risk profile. We'll be dealing with all these things in the next chapter. In a hypertensive individual, what you need to keep in mind is, if tolerated, the blood pressure, systolic blood pressure has to be less than 120. But again, in the trials, hypertensive individuals being recruited to the trial have a high or intermediate cardiovascular risk. But whether actually this needs to be practiced in a low risk individual, we don't really know. Now, coming to the diastolic blood pressures, again, these are actually data from the trials, and you need to keep in mind that none of the clinical trial has recruited a low-risk hypertensive individual. That will be hypertensive with some other extra additional factors, like sometimes they may have some kidney disease, sometimes they may have diabetes, sometimes they might have additional cardiovascular issues like some stable angina or something like that. And again, if we look at the trial data, you don't want to target a diastolic blood pressure less than 60. That's going to be harmful. And 70 to 80 is the optimal target for patients with a treated systolic blood pressure of less than 130 millimeters of mercury. So probably this is going to be the targets we are trying to keep. Systolic blood pressure less than 120, and sometimes we will actually keep it less than 130. Again, I'm coming to that in the next session. And a diastolic blood pressure somewhere between 70 to 80. This is going to be the target for most of the hypertensive individuals with intermediate to high risk. Now, we all have been taught this. I just want to, I already told that we do not really target a diastolic blood pressure too low in certain individuals. And this is because of the existence of something called a J curve. A J curve, basically, when we plot the mortality against the diastolic blood pressure, you can see that when the diastolic blood pressure, ignore these values, this will actually keep on changing depending on the population. When the diastolic blood pressure is too low, there is a risk. And when the diastolic blood pressure keeps on increasing, there is a particular point where the mortality is the lowest, and beyond that, the mortality keeps on increasing. And what you need to keep in mind is this, whether this J curve exists in the general population. That's a huge controversy. And this is mostly, the J curve data is mostly from individuals who have coronary artery disease. So we know that coronary flow happens in diastole. And when the diastolic blood pressure is too low, in patients with stiffened coronaries and left ventricular hypertrophy, when the diastolic blood pressure dips below a certain point, the coronary blood flow will be impeded, and that is the reason why the J curve is there. So again, you can see that after revascularization, this is the shape of the curve when before revascularization, and after revascularization, the J curve kinds of becomes a little bit less benign as well. And again, this is a trial data. So what you need to keep in mind is it does not exist in the general hypertensive population. Whereas if a low risk individual, a low risk hypertensive individual, somebody who is in 45, normal kidney function, there is no cardiac hypertrophy, no stroke, nothing, otherwise healthy, just because the blood pressure is elevated, probably that patient might be a safe candidate to bring down the blood pressure to diastolic blood pressure to somewhere close to 70 and 80. On the other side, an older individual who had who is having a left ventricular hypertrophy or who is having a kidney disease probably might not be the best candidate to bring down the diastolic blood pressure to 70 to 80. So, okay, there are so many controversies about the J curve, and there's no J curve for stroke or kidney disease. So again, but we don't really aggressively reduce the blood pressure and kidney disease because of certain other concerns. I'll come to that. The hypertension, what you need to keep in mind is essential hypertension in a low risk individual. Probably you can actually target a good blood pressure, reasonably good blood pressure control. And depending on the amount of risk factors and age, probably this profile will keep on slightly changing. Now, coming to certain other features of hypertension that you need to be aware of. So, most of the time we measure the blood pressure when the patient comes to the office. And this is based on the assumption that this blood pressures generally tends to be higher in the morning hours, and they generally tend to be much more lower in the night. So there is a phenomenon called dipping. Usually the blood pressures in the night, both systolic and diastolic, tends to be 10% lower compared to the daytime blood pressures. And this is, if this is this black line, that is actually what, if we trace the blood pressure of a healthy individual, that is how it would look like. Now, certain individuals, the blood pressure drops, but not to this level, and they are called non-dipper. And on the other side, there are other individuals where the blood pressure rises during the night time. They will have a normal blood pressure during the daytime, but in the night time, they will have an elevated blood pressure that would remain elevated throughout the night, and by morning it comes down. Now, if such an individual comes to office, there is a very likely chance that we might end up labeling this particular patient as normotensive. And on the other side, there's a group called extreme dipper. That's also going to be bad. That's associated with the very high risk of strokes and other cardiovascular mortality. Now, even when you are normotensive, if you are a non-dipper, that's associated with increased cardiovascular mortality. Like the way of salt sensitivity, even if you are normotensive, if you are a salt sensitive individual, you're going to be having increased cardiovascular risk. And even if you are normotensive, if you are a non-dipper or a riser, again, you are going to have increased cardiovascular risk. Okay, this is what I was telling. Dipping basically is anything within 10 to 20%, or the nighttime BP should be lower by 10 to 20% compared to the daytime BP. So this is what actually a healthy individual's blood pressure profile looks like. This is bad, extreme dipping is bad, non-dipping is bad, and reverse dipping is also bad. Now, okay, because of this dipping, there was a hypothesis sometime back. This is why I wanted to discuss this dipping is, this is something which is related to the dosing of antihypertensive. For a long time, there has been a few randomized trials that has shown that when you can convert a non-dipper to a dipper, there is some improvement in cardiovascular mortality. So because of this, a group of physicians used to give the antihypertensive. I think there's some interference. Whoever is speaking, can you mute, please? Okay. So there was a hype. There was some, because of this studies that has shown that nighttime administration of antihypertensive medication is beneficial. People used to give the single, for example, if the patient is on a long-acting single antihypertensive, there was a hypothesis that it's best given during the nighttime. But again, there were a lot of controversies on the design of this trials, and this is where we stand as of now. The timing does not matter. Whether you gave it in the daytime or whether you gave it in the night time, it doesn't matter. What is more important is compliance. So, if you have a single medication, a long-acting medication, now the present guidelines say there's no difference when you give during the night time or morning time. So, it's up to the physicians and the individual's choice. If the individual opts to take it at night time, well and good. If the individual opts to take it at daytime, again, that's going to be off. Now, all hypertensives coming to you, they need some basic evaluation, but they don't really need a very extensive evaluation for secondary causes. So when you should actually refer the patient to a physician for evaluation for secondary hypertension, most of what you need to keep in mind is most of the essential hypertension, especially the low risk and possibly the intermediate risk, are patients that could be managed in the primary care setting. You need to refer the patients, probably the high risk patients, to the physician or the specialist. Sorry. So, when to suspect a secondary cause, let us say the patient is compliant to salt, the patient is on antihypertensive, and the patient is on 3 medications that includes diuretic, and the patient is compliant with salt restriction and the medication, and still the blood pressure is going to be more than 140 and 90. That is something that is called resistant hypertension. There may be a secondary cause, there may not be a secondary cause, but that is not something that can be managed in the primary care setting. And let's say another scenario, somebody who has been maintaining a blood pressure of 130 by 80. And during the present OPD visit, you are finding that the blood pressure is 160 by 100. And even after repeated measurements, you ask the patient to come on a second day. I think actually I'm seeing a few lines on the slide. I believe actually I'm not doing anything. Abhilash, I think someone is actually drawing on the screen.
Rahul, aതൊന്ന് ക്ലിയർ ചെയ്യാവോ?
I think, can you ask the admin to avoid access to people to my screen?
ഞാനത് നോക്കട്ടെ.
Okay. No, because this line suddenly, I was thinking I am drawing the line, so this line keeps on suddenly appearing. Yeah, okay. Okay, fine. We'll go to the. Okay, so the patient actually had a stable blood pressure, and the patient comes. Suddenly, you're finding that there is a sharp increase in blood pressure that refuses to come down. That's a patient who needs to be referred. And generally, essential hypertension usually appears somewhere around 25 to 30 years. And usually there will be additional, because at 30, for a lean, healthy individual, you don't really anticipate them to be hypertensive. On the other side, someone, an obese or overweight individual coming with 30 with a 140, 90 blood pressure, probably you might be dealing with essential hypertension. A diabetic, a type 1 diabetic, or an early onset diabetes, say let's say coming after 10 years of diabetes, probably that might be the harbinger of underlying kidney disease. You need to refer. So you have hypertension in the absence of risk factors at a very young age and again a very old age. A new onset hypertension after essential hypertension usually makes it beginning somewhere between 30 to 55. So if you're seeing a very young individual with hypertension without any other risk factors and a very old individual with hypertension without additional risk factors, that's again time for referral. And anybody presenting a severe hypertension, a hypertensive emergency or a hypertensive crisis should be referred to the specialist. And any patient with end organ damage, what end organ damage we are going to see whether there's any proteinuria. You get a creatinine done. Maybe let's get an ECG to see whether there's any left ventricular hypertrophy, or at least a physical examination showing a enlarged heart and presence of any features suggestive of cardiac failure, any history of TIA. These are all features of end organ damage. So anybody with end organ damage needs to be referred to a specialist. And a hypertension associated with hypokalemia or metabolic alkalosis. Sometimes you put the patient on a very minuscule dose of diuretics and the patient lands with a profound hypokalemia. That's a scenario where you need to refer this patient. And all pediatric hypertension should be referred to concerned specialist. And if you have access to a 24-hour blood pressure, I would say this is not a really absolute thing. You have a very bad hypertension and you are having a non-dipping pattern or a reverse dipping pattern on a 24-hour ambulatory blood pressure, probably it is always better to get. These are people at a higher risk. It's always better to get an expert opinion. Probably let the specialist actually ascertain the risk, and probably once this patient comes back, you can still continue to manage this type of patients. Okay. Now, I just want to bring your attention to something called a white coat hypertension, which all you will know, and there is something called a masked hypertension also. Both are not really good. They are not just nuisance values. And you should actually, there is something called a white coat effect. A white coat effect is a transient elevation in the blood pressure when a person is in a clinical setting. That it might take some 10 or 15 minutes to come down, and you need to distinguish a white coat effect from a white coat hypertension. A white coat hypertension, they will have persistently elevated blood pressure in the clinic. And the blood pressures are not going to come down till they leave the clinic premises. But when you do a 24-hour ambulatory blood pressure monitoring or a home-based blood pressure monitoring, their blood pressures are going to be normal. So, white coat effect, a transient elevation in blood pressure when they are in the healthcare setting, that should not be labeled as white coat hypertension. You want to label someone as having white coat hypertension, we need to have a home blood pressure recording or an ambulatory blood pressure recording. So white coat effect is basically related to aging and it is not associated with the cardiovascular risk. On the other side, white coat hypertension, probably you consider this like a stress test. When you are in the hospital setting, you always have elevated BP. But suppose if your cardiovascular system is normal, you are not really supposed to have that. And there are large databases which has followed up this white coat hypertensive patients for many years, and they have found that white coat hypertension is going to be associated with increased cardiovascular mortality, even when there are no other risk factors for cardiovascular disease. And in the high risk setting, the effect is even more, a little bit more pronounced. So white coat hypertension, if you come across white coat hypertension, there are no consensus guidelines on white coat hypertension, but probably how to treat white coat hypertension, probably these are a group of individuals who needs an additional care compared to a normotensive individual. So this is again a large database that has actually followed up white coat hypertensive, normotensive, white coat hypertensive and sustained hypertensive over periods of long period of time, and you can find that the chances of having an organ damage, the atherosclerotic organ damage, in the absence of an elevated blood pressure in normotensives is very less. Whereas 1/3 of the white coat hypertensive will have some evidence of an atherosclerotic organ damage. And whereas this is going to be somewhere around 40% in sustained hypertensive. And what you will see is compared to normotensive, the blue is a normotensive line, the organ damage tends to accumulate over period in white coat hypertension. It is somewhere between, it is not as bad as a sustained hypertension, but it is not really as low as a normotensive individuals also. So if you document white coat hypertension, this are the group of individual that needs a long-term follow-up. And the problem is when you see white coat hypertension, whether actually this type of individual needs treatment. So that is kind of a gray zone. So what actually observational data has shown that When these white coat hypertensives are given antihypertensive treatment, the risk becomes normal compared, the risk becomes kind of equal to that of the normal population. Whereas if they are untreated, the risk keeps on increasing as time passes. Now, whether actually somebody with a white coat hypertension, you should jump on to treatment, I would say this is an area where probably you should get a specialist opinion and not treat in the primary care. Refer to a physician, let the physician ascertain the organ damage, and let the physician take a call on antihypertensive therapy and all. So this is an area where no recommendations exist. But what you need to keep in mind is, if the patient, even if the patient does not have any other cardiovascular risk or organ damage, white coat hypertension can accumulate damage over the time. And on the other side, if there is any organ damage, or if the patient has any other atherosclerosis or atherosclerotic risk equivalent, this organ damage is keeping on accumulating over a period of time. Now, coming to even a yet more dangerous thing, which we will be blissfully unaware, is something called masked hypertension. So, masked hypertension, the office measurements are always going to be normal, and these patients are not on antihypertensives. But when we do a home blood pressure measurement or an ambulatory blood pressure measurement, their blood pressures fall within the hypertensive range. And when such a phenomenon happens in a hypertensive, you don't call it as masked hypertension, you call it as masked uncontrolled hypertension. And again, both having a masked hypertension and having a masked uncontrolled hypertension is not going to be good. And always we should keep in mind that those who are labeled as pre-hypertensive, or now we call them as having elevated blood pressure, these are the candidates who actually we should ascertain that we are not dealing with a masked hypertension. And now, why actually somebody's blood pressure? We all know what is the reason for white coat hypertension. It's probably the adrenergic stress or sustained sympathetic activity that keeps the blood pressure shooting up. Then why on earth actually somebody's blood pressure should come falling in your clinic? So the first thing, if you remember the graph I shown, there is something called a nocturnal hypertension, the type of non-dippers whose blood pressure keeps on increasing, or what we call as the reverse dipping. Such type of individuals who are vulnerable for such phenomenon, metabolic syndrome, somebody having a diabetes, somebody having kidney disease, somebody having sleep apnea, they will have hypertension only during the night time, and their office measurements are going to be always in the normal range and maybe sometimes in the pre-hypertensive range. The other situation is older individuals. Generally, sometimes it's not uncommon to see older males with very high BP variability, and especially when they visit the clinic after postprandial in the postprandial state, maybe because of the splanchnic vasodilatation, their pressures, probably systemic pressures, might be in the normal range. And this people, when they go home in the night, instead of their blood pressures coming down, it keeps on increasing. Then sometimes somebody who is actually little more relaxed in the clinic, but there is a lot of mental stress going on around work and home. So they are spending 10 or 15 minutes in the clinic where their blood pressure is going to be normal. On the other side, the rest of the day, the remaining 22 or 23 hours they are spending at home, and their blood pressures are going to be always elevated. Then smokers and alcoholics, maybe the vasodilated states probably sometimes can mask the blood pressure. And sedentary obese individuals with poor exercise tolerance, the blood pressure shoots up when they start exercise, and when we measure BP in a relaxed state, so their blood pressure is not going to be high. But these are individuals who are actually at risk of increased cardiovascular, and the most important thing is the masked uncontrolled hypertension. People take up medications just prior to the hospital visit. They might skip all the medications rest of the time, but they might actually take a medication an hour prior to the visit to the physician. So it's always better. The advantage of home blood pressure or ambulatory blood pressure measurements is there are certain phenotypes we are going to miss in the clinic. And there are certain phenotypes you're going to overdiagnose in the clinic also. So when it comes to cardiovascular morbidity and mortality, rather than the office measurement, it's a 24-hour measurements that's more important. You need to ensure that the blood pressure is reasonably controlled for the entire day and not simply when the patient is in your office. So what happens to this masked hypertensive? They will continue to, majority will continue to have masked hypertension, and a third will actually progress to sustained hypertension. And even if they don't become hypertensive, they can contribute to progressive organ damage, and nothing happening probably is going to be a minority. Only one third will regress to normotension. And again, this is some longitudinal data showing the outcome of patients with this continuous lines are masked hypertension, treated and untreated. But you can see that this bold line is basically the untreated masked hypertension. The cardiovascular event rate keeps on increasing with passage of time. And when you treat, you can see that basically this is the bottom line. You can see that the cardiovascular risk is going to be much more lesser when compared to untreated masked hypertension. And again, this is a meta-analysis of whatever available literature. We don't have any trial data or anything. So obviously, white coat hypertension and masked hypertension, it's very, very unlikely that we will have any trial data. So we'll have to look into the large observational studies. And what actually this graph show that compared to normotensive, masked hypertension is going to be associated with increased cardiovascular risk. And again, masked hypertension is a little more dangerous than white coat hypertension, because white coat hypertension, probably the time frame where the patient is having hypertension might be way much lesser compared to that of a masked hypertension, and they tend to have a much more higher risk compared to the white coat hypertension also. Now coming to the last part, how do we measure the blood pressure? So all these guidelines, hypertension definitions are based on office blood pressure. So in the office blood pressure, you can use your traditional manual BP apparatus. You can use a mercury manometer, but now for the last couple of years, it's no longer available in India because of the mercury ban and all. Or you can either use an office conventional measurement, or you can use an automated equipment. There might be kiosk in the hospital where patients can walk in, and there won't be, this is unmanned kiosk. If such a facility is there, you can use that. And the problem with office blood pressure measurement is there is increased risk of white coat hypertension, and we might end up over-diagnosing, and we might end up over-treating. And again, despite all the observational data, whether white coat hypertension needs to be treated, that's again a gray zone. And out of the office measurement, the advantages is probably you are eliminating the stress factor. The advantage is that probably you are going to see those patterns, pathologic patterns like masked hypertension, reverse dipping and non-dipping. You will be able to identify with an ambulatory blood pressure measurement. These are the various equipments we use. All of you might be familiar with all this mercury manometer, aneroid manometer, and the oscilloscopic device. And only one thing you need to keep in mind is whenever you are using an oscilloscopic device, the principle of working of an oscilloscopic device is something different. So this oscilloscopic device actually senses, the cuff senses the oscillations in the artery. And maximum oscillations will be there when it's closer to the mean arterial pressure. And from this mean, it's actually the mean arterial pressure that the cuff actually measures. But the problem is we will not be able to take a clinical decision if the equipment gives you the mean arterial pressure. Because all the studies, all the data, all the classifications are based on systolic and diastolic blood pressure. So basically the equipment has a proprietary regression equation fed in the equipment, and the microchip does that processing, and using this regression equation, it gives us a systolic and a diastolic blood pressure. And this regression equation is proprietary, which means that each manufacturer will have their own equation. Because it's an equation, there is nothing called actually the best equation. So what they do is they will have the equipment, and they will actually compare it with the other equipments, other methods which use non-oscilloscopic devices, and this equipment will be validated. So whenever you are using an oscilloscopic device, you need to ensure that you are actually using a validated equipment. In the subsequent sessions, I might be showing a link which actually will take you. You see any blood pressure guideline by any society, there will be links to this oscilloscopic equipments which are validated and recommended. There are a lot of equipments, but the only thing is use a validated equipment if you are using an oscilloscopic device. So again, this is largely the same thing. The patient should be relaxed and exercise. Caffeine, smoking should be avoided half an hour before. And yeah, this was what you can actually, that validatebp.org is a website where you can cross check whether your oscilloscopic equipment is validated or not. And you have to use the correct cuff size for the patient, and the arm supported at the blood level. The patient should be sitting in a chair. This is very important. It should not be supine or standing. And the posture is also important. Do not cross the legs, and the patient should give back support. So it should be a chair, not a stool, which actually we use in many of the OPD settings. And nobody should talk. That's again important. And no access to phone. In a temperature controlled room, it should not be too cold or too warm. You need to take 2 or more blood pressure measurements at least 1 minute apart. And again, if the blood pressure recording is abnormal, do not label the patient as a hypertensive. We need to repeat the process on a different occasion to label someone as hypertensive. So, what is the use of out of office blood pressure measurement, which includes home blood pressure measurement and the ambulatory blood pressure measurement? It's recommended in confirming hypertension. For example, someone coming with a blood pressure of, let's say, 140 by 90. And in a different setting in the house, if it's coming normal, then we are dealing with a white coat hypertension. And it's extremely important in monitoring medication. This practice of popping the pill before coming to the office, that's quite rampant in Tamil Nadu. What type of patients I see, they don't take the pill on the day they come to the doctor. But a little bit educated patients, they have this tendency of popping the pill an hour before, and they know what is the medication that will bring down their blood pressure, especially somebody on multiple medications. And that actually it misleads the physician. And of course, like the advantages are, I told you will actually see the abnormal blood pressure pattern. And this early morning surge, I did not really talk much about the nocturnal blood pressure, but that nocturnal hypertension, that also is pretty bad. The nocturnal hypertension is also associated with increased adverse cardiovascular outcomes. And other thing is, sometimes actually the patient will come with hypertension, and the reason might be, it might be a reactive response to hypertension happening sometime also. And this type of patients, we need to reduce antihypertensive medications rather than keeping on increasing it. Just a minute, I'm muting my mic. Now coming to the ambulatory blood pressure measurement. And again, we have to use a validated device. Usually the cutoffs for ambulatory blood pressure measurement is 10 millimeter lower than the, if we take the average 24-hour blood pressure, it's going to be somewhere around 5 to 10 millimeters lower than the office measurements. So 140 by 90, the equivalent ABPM, if you use a hypertension definition of 140 by 90, when you are using an ambulatory blood pressure measurement, the definition you have to use is 130 by 80 over a 24-hour period. But if you're simply looking at the daytime measurement, it becomes 135 by 85. And for nighttime measurements, it's even lower. It's going to be 120 by 70. There are a lot of devices, and most of these devices records blood pressure at 15 to 30 minutes interval during the day, and night 30 to 60 minutes interval. And at least 70% of the readings should be available. And patient has to keep a diary. This is actually supposed to be done in a day where when the activities of the patient is very close to the usual routine activities, which means that they should not do very unaccustomed activities that needs a lot of physical exertion. Say having an ambulatory blood pressure measurement and going for a trek. That's not actually that we want. The patient has to be in the normal circumstances. instances. And again, you need to keep in mind that there is no need for the patient to take a rest or anything. If the patient is going to the office, the patient can go to the office with the ambulatory blood pressure measurement, wear it throughout the office, come to the home, take rest, take sleep, as the patient is going to do in a usual setting. And again, home blood pressure measurement, it's important that the device should be validated. And again, there are many websites. This is one of it, which actually where you can go and cross check. And what you need to keep in mind is these are the instructions. Same thing, no beverages, smoking, no exercise within 30 minutes. Position again, seated in a chair, legs not crossed, the elbows supported on the table. And you should not attend a phone, and you should not be watching television, because sometimes certain TV programs can actually cause an adrenergic surge. It's actually, you should be in a perfect rest, and you should take 2 readings, 1 minute apart, twice a day, and a total of 4 readings. 2 readings in the morning after voiding and before taking the medication and eating, and 2 readings at bedtime just before going to sleep. And you will have to take in a week, you have to take 3 days minimum, and preferably you take for 7 days before your appointment or interaction with your physician. And always write it down. And some of the home BP machines, there is an electronic log. If that's not possible, you have to specifically instruct the patient to write it down. And again, this was what I was telling. So when we use an office and ambulatory blood pressure measurement, there is a difference. And in low to moderate risk individuals, this difference is lower. And in high risk individuals, the difference is even higher, which actually means that probably when we just take the decision based on the office blood pressures, probably we are missing the bigger picture. And again, ambulatory blood pressure is a better, because it actually gives us an idea about the cardiovascular risk, about the 24-hour control. A controlled ambulatory blood pressure round the clock actually is better for your cardiovascular profile. And same thing happens for if you risk stratify patients based on ambulatory blood pressure and home blood pressure measurements, both performs better compared to office blood pressure measurement. So what you need to keep in mind is hypertension is a disease with a genetic susceptibility, but just being born with some susceptible genes doesn't make you hypertensive. You need to have multiple hits that accumulate during your lifetime. And the best outcome in the general population, systolic blood pressure should be less than 90, and the diastolic blood pressure should be somewhere around 70 to 80 ranges. And this applies to most of the hypertensive individuals also. But there are certain exceptions, which I will be dealing in the next chapter. And if possible, you have a setting, do a ambulatory blood pressure monitoring, or at least a home blood pressure monitoring. And white coat hypertensive needs to be followed up. Whether they need to be aggressively treated, we don't really know. And masked hypertension is something which goes outside the radar. So that's where actually the home blood pressure measurements and the ambulatory blood pressure measurements comes into play, especially in a patient who is at risk or who is having organ damage. Ensure that actually we have a couple of readings outside the office also. So that's all I have for today. And in the next session, I'll be dealing mostly with the management, and maybe a little bit on what actually can be done when you come across hypertensive disorders of pregnancy in the primary care.
Thank you, Dr. Priyamvada. We'll have a question and answer session at the end. First question has come. Frothy urine complaint in PHC OPD.
Okay, frothy urine generally doesn't froth, and if froth is there, that means basically the patient is having some kidney disease. So such patients should have a urine albumin creatinine ratio done. I don't know how many of the PHCs offer the albumin creatinine ratio, because like many centers, it will be urine protein creatinine ratio, where the detection threshold is way much higher. So you need to do a urine albumin creatinine ratio. If it is less than 30, well and good, and you need to get a creatinine for this patient. And a normal creatinine again is not going to be of much of a use, because there are so many fallacies. You can use any validated formula to check the estimated GFR. A lot of eGFR calculators are available. So we don't have any validated formula in the Indian population. So what we use is something called a CKD EPI formula. Until we have a validated formula in the Indian population, we can use the CKD EPI formula. And if the CKD EPI formula gives a good GFR, that's a GFR of more than 90, and a urine albumin creatinine ratio of less than 30, things are going to be okay. And I believe that that patient can be managed in the primary care, provided the patient is not a high risk individual. Like the patient does not have cardiac failure, the patient does not have very difficult diabetes to manage and all. And
Another question.
another important thing I would say is actually, okay, this people might not be noticing the most of the time when you flush, when you urinate into a commode, you should ensure that there is no residual toilet cleaner there. That's an important reason. Immediately after cleaning the toilet, you void, there will be traces of toilet cleaner, which actually will create the froth. It's like a soap which reduces the surface tension. So I had patients coming to me telling that there is a froth in the urine. After extensive evaluation, nothing. Then a little bit detailed history revealed that the house is being cleaned in the morning, and this particular person is the first person to use the toilet after the cleaning part.
Evaluation of serum creatine management. Other
Not every elevated, I told you, elevated serum creatinine, it should be GFR. And normally you can have, see, because your creatinine starts getting elevated when you lose around 50% of your GFR. On the other side, you are having a very skinny patient with hardly any muscle. And normal creatinine also doesn't really mean that he is outside the danger zone. So probably, I think actually, if a patient, let me use the term low GFR rather than an elevated creatinine. If a patient comes with a low GFR, you can actually get an opinion from a physician. And not every patient with a low GFR needs to be referred to the nephrologist. For example, in my clinic, what I do is, if the GFR is less than 30, then only I ask the patients to be attached to a nephrology clinic. And there might be a lot of patients with GFR somewhere in the like 50-60 range and not progressive. Like let us say we have multiple readings over 2 or 3 years. These are the type of patients who can be easily managed in the primary care. The only thing is the targets are going to be slightly different, but not really grossly different from the general population.
Another question is difference between refractory and resistant hypertension. These they have different definitions.
No. Everything is kind of simplified. It's only resistant hypertension. So, refractory hypertension was a term that used to be. Now, the current tendency is to call everything as resistant hypertension.
Another question is relevance of BP monitoring in both arms.
Yeah, that's something which I had forgotten to. So, first visit, basically, you have to monitor blood pressure in both arms, and in the subsequent visits, you have to monitor blood pressure in the arm with which records the highest blood pressure.
Okay. Another question is please
You need
explain
to
the
give a 5 minute gap between this arm measurement in both arms. So it's mandatory that every patient coming to the clinic first time, blood pressure should be measured in both arms. And now whether the patient is normotensive, hypertensive, you document which arm has the highest blood pressure. Then in future visits, you continue to measure in the same arm.
Okay. Another question is please explain the management of white pulse pressure bar bradycardia. Example BP 176 by 58, pulse rate 56, ECG sinus arrhythmia.
I
White,
think
white
actually
pulse.
I'll deal with that in the next session, because that's good. I think actually part of this question will be answered in the next session.
Okay. Another question is LVH like ECG with a normal BP. Is unmasked hypertension a possibility?
This is the type of patients. Yes, it definitely might be possible. See, what you need to understand is left ventricular hypertrophy can occur in the absence of hypertension also, in the clinic also, as well as ambulatory blood pressure also. So this is ideally the type of patient who should have a home blood pressure monitoring, or best is actually an ambulatory blood pressure monitoring.
Another question is urine albumin creatine ratio over 800 with a normal creatine in a 50-year-old female with diabetes and hypertension. How to evaluate further?
Okay, this patient, I believe the patient should be on AC. This patient might actually need AC inhibitors and all. What I would say is actually like you just, it's better that this patient is referred to an internal medicine specialist for further opinion. And probably once the treatment is stabilized, you can actually, I assume that probably this patient is being managed by someone with an MBBS qualification. Better to get an inter-physician opinion, and once actually the physician manages this patient, optimizes the treatment, this type of patients can again come back to you and follow up in the primary health center, because this is a patient where you need to assess the risk profile. The patient might actually need assessment for cardiovascular disease. The patient might need assessment for retinopathy and all, which probably I believe might be difficult in the primary care setting.
Another question is you see a high BP reading. The patient says he was off antihypertensive since 3 to 5 days. Do you ask to continue the same medicines or increase
No,
antihypertensives?
that is actually, this is something which you should tell the patient when you start antihypertensive. They have to come to you with the blood pressure medication. Otherwise, if that is not there, if they're doing a home-based blood pressure monitoring, or if they have some periodic ambulatory blood pressure monitoring, that's fine. And I know periodic ambulatory blood pressure monitoring, that's going to be very difficult thing. If you pay for that, that equipment is going to be quite costly and all. So, okay, in the absence of a home blood pressure monitoring, so what I do, what I ask my patients is, if they can afford a blood pressure apparatus, a validated apparatus, which usually will be able to get in 1000 in 2000 range, I would ask them to maintain a home blood pressure chart. And it's like it makes your job way much more easier. You have access to the morning blood pressure, you have access to the evening blood pressure, and you are not actually compelled to change your decision just because of a random normal or a random abnormal blood pressure monitoring. This patient, the best advice is ask the patient to go back, continue on same medications, and come back after 1 or 2 weeks.
Another question is in which situations can we use cystatin C to calculate EGFR?
Okay, cystatin C, normal primary or even secondary care, probably like that's not going to be required. So there are certain scenarios, for example, what we are actually calculating GFR based on certain equations. Now, let us say less than 60 ml is CKD. Now, somebody with 59 ml is labeled as CKD, and somebody with 60 ml is labeled as 61 ml is not labeled as CKD. Let's say an older man comes to us, let's say 70. At the age of 70, the usual GFR is going to be somewhere between 50 to 60. So, you have a normal sized kidney, there is no proteinuria. So these are actually things which tells you that there is a renal damage. So certain individuals with a normal sized kidney, there is no albumin, elevated albuminuria, and the GFR is in the 55 to 60 or maybe 50 to 60 range. The question is whether they have CKD or not, whether it is simply just a low GFR. In such situations, because the problem is when you label the patient as CKD, they're going to carry the stigma, and there will be a lot of implications in the future, starting right from the insurance. So such patients, like it's recommended that you use something else also. You can use a formula which incorporates creatinine and cystatin C. Second thing is an older individual coming as a donor. So if the patient has CKD 59 ml, you cannot take out the kidney. If the patient doesn't have CKD and if the GFR is 59 ml, maybe after explaining the risk, we can still take the kidney. So these are the usual situations, and most of the time, it's not really. And the other thing is cystatin C. The problem with cystatin C in India is we don't really have a. There could be a lot of inter-assay validation issues will be there. For creatinine, there is something called isotope mass IDMS. So this every single creatinine assay we use should be validated against IDMS. So there's a reference standard. But whereas for cystatin C, that reference standard has not been established. So simply looking at cystatin C value from one lab probably is not going to be of much help.
Another
Yeah,
question is
there are
normal
certain
digital
other
B.
situations which probably is in the specialist domain. So I would say in the primary care, please don't check cystatin C. You are going to land in more issues with cystatin C.
Is normal digital BP apparatus available in the market good enough for BP recording in hospital setup?
Yeah, you can use it, but most see, we also use oscilloscopic devices. Now, mercury manometers are not available for the last couple of years, and aneroid manometers, our hospital has stopped purchasing aneroid manometers. So now what is available is the oscilloscopic one, which we use for the home blood pressure monitoring. And there are actually home BP monitors with memory and all. So that is a little bit costly equipment. And I believe actually some trials were going on. I'm not sure whether it is licensed for use in India. Couple of years, such a few trials were going on. So what we use is oscilloscopic equipment, which people use for checking their blood pressure. But only thing is, when you, whatever you are using, I know that in government setup, there is this tendency to purchase L1. So the person who makes the purchase, if they haven't done the homework, there's a small possibility that you might end up getting a non-validated equipment, especially with the current practice of encouraging local manufacturers and all. But just ensure that whatever you use is a validated one.
Another question is causes of anisospicnia.
A 5 to 10 millimeter difference can be physiological, but suppose if it is more than that, usually there might be a secondary cause like a vascular narrowing or something causing a narrowing upstream, and sometimes even 10 millimeter blood pressures there might be. If it's more than 10 millimeter difference, the patient needs evaluation, but sometimes even after extensive evaluation, we might not be able to find. Generally, 5 to 10 is considered as normal.
Which which NSAID can be preferred in CKD patients with osteoarthritis, moderate to severe pain?
I would say actually like none of the NSAIDs are safe in patients. You can go for tramadol if there is severe pain. If it's mild pain, probably it's paracetamol. Tramadol, again, you have to keep in mind that it's a scheduled drug, and there's an abuse potential also.
Whom should we suggest
Or the
renal
other thing, you can actually give this topical applicants are there. So capsaicin cream and all, you can apply. But somatic pain, severe pain, the type of pain caused by osteoarthritis, we don't really have other options except than using narcotic agents.
Whom should we suggest a renal artery Doppler to rule out a RAS, renal artery stenosis?
Renal artery stenosis. So, in someone who is actually having a very high index of suspicion of a renal artery stenosis, for example, you are hearing a bruit, renal artery bruit, or the patient has severe atherosclerotic disease in other vascular beds and comes with very difficult to control hypertension with hypokalemia. Hypertension patients, creatinine rising with RAS blocker. These are the type of patients for whom you need to rule out renal artery stenosis. Someone presenting with flash pulmonary edema, again, you need to rule out a renal artery stenosis.
And next, how to confirm renal artery stenosis in a patient here?
So let me tell you, the Doppler, the problem is the only foolproof method that's going to confirm or that's going to refute a diagnosis of renal artery stenosis is imaging, a CT or MR imaging. The problem with the Doppler is the sensitivity of the Doppler is somewhere around 95%. It's not 100%. And there are so many Doppler criteria also. Like there are velocity based criteria, then there are criteria based on the graph and all. Each will have a little bit of differing sensitivity. So if the Doppler is highly suggestive of renal artery stenosis, then the other important question is most of the time, single renal artery stenosis is not sufficient enough to produce kidney failure. Most of the time, what you are looking is atherosclerotic renal artery stenosis. The other important question is whether this patient should be revascularized. Most of the patients with atherosclerotic renal artery stenosis are not candidates for revascularization. I believe in a primary care setting, if the Doppler is normal, I think actually you can stop at that point.
Thank you. There are no more questions.
So thank you, Abhilash.
Okay. Thank you. Dr. Priyamvada, for agreeing to enlighten us on this topic. So today's session was the first part, and hope we are eagerly waiting for the
Yeah,
second
I
part.
think this is more of a theoretical part. So, at least what I want at the end of the day is emphasize the salt restriction. Second thing is, if possible, encourage home BP monitoring. And if any of the PHCs are, if you have a mechanism to procure an ABPM equipment, get an ABPM equipment also.
Dr. Shanu PM from Kottayam has
Yeah,
sent a
hi
message.
Shanu. So it's long time back. It's almost like yeah, 15 or 20 years, right?
Yes, ma'am.
Uh,
Yeah.
How are you?
So you are in Kanjirapalli, or where are you now?
Yeah, back to Kanjapalli now.
I've seen your board while passing through. Maybe next time I'll drop in.
Oh, okay. Thank you.
uh, on the on behalf of KGMOA Academic Cell, I thank Dr. Priyamvada for agreeing agreeing to take the class. Thank you very much. We are eagerly waiting for the second session, the
Yeah, I'll
management.
have sometime in January because next month I'm going to be kind of busy. A lot of
No
travel
problem.
is there. Let me see whether
You
I
can
can do
take
it
it easy.
earlier. Okay. Okay. Yeah.
Okay, okay. Thank you. Thank you very much.
Thank you.
Thank you.